Hi, everyone. Good evening. Welcome to tonight's Resident Education Club webinar presented by the Society of Skeletal Radiology. I'm Jennifer DeMertzis. I'm a private practice radiologist in St. Louis and secretary of the Society of Skeletal Radiology. And I'm very pleased to be serving as tonight's moderator. I'd like to introduce you to Dr. Iman Khodarahmi from NYU, who's going to be presenting tonight's lecture on arthroplasties. And without any further ado, he has a lot of great information and great cases to share with you tonight. So Dr. Khodarahmi, please begin.
Thank you, Jennifer, for the introduction, and thank you, SSR, for the opportunity. So in this 45-minute talk, we're going to be speaking about the interesting cases of hip arthroplasty. And I assume that you're able to see my screen. So I have few cases, and then after each case, I'm going to give you explanation on the findings. So for each case, I'm going to pause for a few seconds and feel free to think about it. And if you'd like, you can actually put your diagnosis in the chat. If you don't feel like it, that's fine. We'll go over the findings. So no disclosures. So this is the first case. So I'm going to give you 30 seconds to think about it. So this is a patient with left-sided hip pain. Obviously, we see arthroplasty, and rule number one in radiology is that, is there a prior? And yes, there is a prior, and this is 12 months prior. Look at the arthroplasty and see what you think. Okay. So I'm gonna go through different configurations of the arthroplasty, and then we'll come back, revisit this case again. So radiographs in arthroplasty is basically number 1, 2, and 3 modality of choice. So basically, we use radiographs for initial assessment right after the surgery to make sure that our arthroplasty is appropriately positioned. In asymptomatic patients, they usually get radiographs as a continued follow-up modality. They may get like radiographs every year to make sure that the fixation is good, there is nothing bad going on. And even if there is pain, the first modality, regardless of the cause of the pain, is going to be radiographs. And then depending on the findings of the radiographs, we may switch into CT, MRI, or ultrasound. So in this talk, I'm not going to be talking about the immediate post-op positioning of the radiographs. That by itself is a separate discussion. But I will touch base on the 2 other areas where we use hip radiographs. Okay. So what type of implant? Whenever you see hip arthroplasty, first you have this question that you need to answer. And the question is, what type of implant are we talking about? Is it a total hip arthroplasty? Is it a hemiarthroplasty? Or is it a less common one, tripolar arthroplasty? And then the total arthroplasty, they have a standard bearing or dual mobility. In hemiarthroplasty, we have the unipolar and bipolar. And I'm going to tell you the difference between these and how we can differentiate them on imaging. So let's start with the classic one, total hip arthroplasty. The term total, it means that we replace both the femoral head and the acetabulum. The most common cause for total hip arthroplasty is osteoarthritis. And that makes sense because in osteoarthritis, both the femoral head and acetabulum are affected. So obviously you want to replace both. And then we have like other forms of arthritis. It may result in hip replacement or sometimes fractures. So what is a total hip arthroplasty? In general, there are 2 components. One is the acetabular component, and the other part is the femoral component. So femoral component may have multiple subcomponents. So it has the femoral head and it has the stem. Acetabulum, it may be a single piece, or it may have more than one piece. So in this case, for example, it has 2 pieces. One is the metal shell, the outer part, and the other one is a plastic liner, the inner part. So on CT, we can see it better. So this is the proximal aspect of the femoral stem. This is the femoral head. The radiolucent part is the plastic liner in this case, and the outer shell is metallic. And this is how we see it on radiographs. So femoral stem, femoral head, and the acetabulum, and obviously the liner is basically a lucent component that the metallic part overlies it, so you may not see it beautifully on radiographs. So this is a total hip arthroplasty. So total hip arthroplasty has different configurations. It's important that you should be familiar with these configurations, but nobody expects you to comment on the exact configuration in your reports, but to see the pathologies that can be associated with hip replacement, it's actually pretty useful to know what type of arthroplasty we are dealing with. So depending on the acetabular component, these total hip arthroplasties are either monoblock or modular. Monoblock is whenever you have a single piece. For example, this configuration here is a monoblock. So if this is a metal on metal, we don't have a liner here. The acetabular cup is this metallic piece over here. Sometimes the monoblock can be two pieces. It can be an outer metallic thing and an inner plastic thing. But the point is that these two pieces are basically firmly attached together. So if at some point the surgeon needs to go inside and replace one, they have to replace the entire thing. So there is no two separate pieces that the surgeon can replace one of it. As opposed to that, that's the second configuration is the modular component. So basically, in this case, we have two interchangeable parts. For example, in this case, you have a ceramic femoral head, you have this plastic liner, and then you have this metallic cup. So this liner sits into the cup. So if at some point there is a problem with this plastic component, the surgeon can replace only this part, not the entire page, right? This is another case of modular. We have the femoral head, we have the plastic liner, and then we have the metallic cup. In this case, the difference between A and B is that in A, the motion is only between the femoral head and the yellow plastic liner. In this so-called dual mobility, we have two levels of motion. One is between the femoral head and this liner, and the other level of motion is between the liner and the acetabular cup. Why is it useful? Because you have two surfaces for motion, so it gives the patient a better range of motion after the hip replacement. And studies have shown that the risk of implant dislocation is smaller whenever you have dual mobility as opposed to single mobility. So this is another case of modular. So we see that this is the metallic head. This is the plastic liner, and this is the outer metallic shell. Again, we are dealing with the modular acetabular component. We can replace this piece here or this piece here. How about hemiarthroplasty? Hemiarthroplasty is a kind of arthroplasty in which the acetabulum is not touched. We only replace the femoral head and neck. So obviously it makes sense that we use this hemiarthroplasty in cases where the acetabulum is healthy. The most common application for these hemiarthroplasties are femoral neck fractures. And the reason is that in these patients, there is only a fracture in the neck. The acetabulum is normal. So we don't want to touch something that is already normal. So we do a hemiarthroplasty. And if the patient needs a total hip replacement in 10 years from now, then the acetabulum is going to be normal. And then later on, we can switch to a total hip arthroplasty. But there is no reason to touch something that is normal at this point. So again, similar to total hip arthroplasty, we have two types. We have a unipolar and we have a bipolar. So unipolar is a hemiarthroplasty in which, as you see it on the right side of my screen, in which the femoral head is basically, there is one level of motion which is between the femoral head and the native acetabulum. This is the implant itself, and this is a similar implant or probably the same implant in vivo. So this femoral component, the stem, is firmly attached to the femoral head, and there is motion between the native acetabulum here and the femoral head. this is on CT. You see that there is no extra motion between these metallic components, and this is the how you see it in the outside the patient. So as we said, the motion occurs between the prosthetic head and the acetabulum. Bipolar, it is similar to dual mobility total hip arthroplasty. So in bipolar, you have a polyethylene liner inside the outer component. So in this case, you have two levels of motion, one between the prosthesis head and cup, and the other one between the cup and acetabulum. So you can see beautifully on this case, this is the native acetabulum. This is one component, cup, and this is the femoral head. So there is one level of motion between this one and this, and a second level of motion between the cup and the native acetabulum. This is the case. And you see that you can see the acetabulum, the native acetabulum beautifully over there. So again, the hypothesis that with bipolar arthroplasties, there is increased range of motion and decreased risk of prosthesis dislocation. So how can we differentiate? I see this sometimes challenging for our residents to differentiate total hip arthroplasty versus bipolar hemiarthroplasty. And there are a number of features that we can use. So first of all, and I think this is probably the most useful feature, is try to find the acetabulum. In this case, cannot see the acetabulum as opposed to this one. You see the acetabulum beautifully here. So this is a hemiarthroplasty, and it's bipolar because we see those two pieces. This is the total hip arthroplasty, the standard total hip arthroplasty. So that's one feature to use. The other feature is, in general, not always, because every manufacturer may come up with a new design. In general, the femoral head is smaller in cases of total hip arthroplasties. So for example, in this case, you can see that the size of this femoral head is smaller than this one. This is something that can be helpful, but not necessarily always. The other feature is that if you see screws or holes associated with the cup, then you know that this is a total hip arthroplasty. In this case, you have a hole here. So the cup of hemiarthroplasties, they never have any hole in them. So if you see a hole, then you know that this is a total hip arthroplasty. So I have a case of this here. So this is bilateral total hip arthroplasty. You see that we cannot see the native acetabulum on either side. The femoral heads are relatively small, but without the side-by-side comparison, you may not be able to say that with confidence. We see the screw on this side, so this is also reassuring that this is a total hip arthroplasty. And on this side, you see these holes, these lucencies here. So this is also a feature that you only see with total hip arthroplasties. So you can think of these holes as holes that they just decided not to put a screw to it, although from a biomechanics, they may have other implications in the prosthesis design. But regardless, you see holes and screws, then it's a total hip arthroplasty. So now let's go back to case one. Now let's decide if this was a total or hemiarthroplasty. I can see the acetabulum very well, right? Acetabulum is here. So this is a hemiarthroplasty. Now the story has changed because I'm dealing with a hemiarthroplasty. 12 months ago, this was vertical. Now it's a little bit flat. But we know that for a bipolar hemiarthroplasty, we have one level of motion between the cup and the acetabulum. So it's a normal finding. So this was a tricky question. I wanted to trick you into saying that this was a total hip arthroplasty and the acetabular component has rotated, but that's not the case. This is a hemiarthroplasty, a bipolar one, and it's totally normal for the acetabular cup in a bipolar hemi to rotate between among different examples. Okay, so more on total hip arthroplasties. So case two, it's not really difficult to make this diagnosis. We see that something is definitely wrong. So the femoral stem is completely out of the femoral head, and this is how you see it on on the coronal CT image. So not a diagnostic challenge at all. So this is a case of, you can call it disengagement of the femoral component, the stem from the head. Companion cases, you see these dislocations a lot. This is a dislocation of the total hip arthroplasty. So you see that the femoral head is out. And this is a hemiarthroplasty. Obviously, in this case, you see the cement here. So this patient had infection, had a prior hip arthroplasty complicated by infection. They took out the arthroplasty out, and now they are putting this antibiotic-coated hemiarthroplasty. So in these cases, there is dislocation of the arthroplasty. So this finding is similar to dislocation of the native hip, not a diagnostic challenge at all. The only point that I can tell you about these cases is that sometimes you're not lucky to see the dislocation very well on the frontal view. So just make sure that you look at these radiographs on two views. So the frog leg view can be really helpful to show you the dislocations. So now, seeing these cases, let's talk a little bit more about the femoral stem. So similar to the acetabular one, the femoral stem can be a single piece, monolithic, or it can be modular. I can tell you that nowadays it's mostly modular, and the reason is that different patients, they have different sizes of their femur, they have different angles of their femoral neck. So there is no one single implant that can fit every single patient. So in the OR, the surgeon, and before the surgery, the surgeon makes some measurements of the patient, and they decide on the length of this one component, on the angle of the component. So because of that, most of the hip arthroplasties nowadays are modular. And to review the anatomy, this is the stem, you already knew that. This is the neck. And this is the taper. Taper is a piece of the neck that is basically going into the femoral head. This is the head here. In this case, there is this lucency here, so we know that this is a polyethylene liner. And this is the shell with the screw. We already reviewed those. Okay. So a few additional configurations. Again, this is for your own knowledge. You don't have to comment on these in your report. So this is a loaded taper hip arthroplasty. We see that the configuration of this system is a little bit different from the other ones. So the surface of this arthroplasty is really smooth and well polished. It usually sits within the cement, and the reason that it's really smooth is that we do this on purpose so that the femoral stem basically subsides into the cement. So we put the arthroplasty here, and in a few days or maybe like in a month, we see that this femoral stem is actually moving a little bit in the cranial direction within the cement. That's expected. We do this on purpose. The other configuration that we may see is a composite beam. It has a rough surface, and sometimes it has a collar. So the rough surface is a good thing because it basically promotes more increased bonding between either the cement and the implant or the bone and the implant. Just two configurations to know about. Okay, so case 3. So believe it or not, sometimes this is the history that you get. They don't even care to like type in evaluate. They only say eval. And then we have to come up with a story that makes sense. So I'm gonna pause here for 30 seconds. So we already know that this is a total hip arthroplasty because we don't see the acetabulum, we see screws. So anything abnormal here? Okay, I'll give you a hint. This was 1 hour before. So we already said that dislocations of these arthroplasties is very common. So this patient came in with a hip dislocation, and then in the ER, it was reduced, and this was after reduction. So again, more hints. I'm going to give you another radiograph from 3 months ago. This was before dislocation. So now we can compare this one and this one. So if you look at this one, the baseline study from 3 months ago, the femoral head was right at the center of the cup, right? Now this is the femoral head here, and it's not really at the center. So what happened? Look at this lucency here. When the dislocation occurred, it wasn't just the femoral head. The liner, the plastic liner was also dislocated. So during reduction, they were able to reduce the femoral head, but the liner is still there, this lucency here. So this is actually a nice case because you don't see these liner dislocations very often. So my teaching point for you is that do not concentrate only on the metallic components. Just look for the plastic components to see where they are. And once in a while, you're able to find those. And if you didn't believe me, these are the coronal images of the same patient. And you see this plastic liner that is not reduced in the acetabulum. And if you're asking me what this finding was, so this patient had this arthroplasty 3 years ago. They brought the proximal aspect of it. So they revised the arthroplasty. They put some cerclage wires here. And this is basically related to callus formation related to that old fracture. And the rest, we know. So let's move on to the junction of the different components. Basically, we are interested to know where motion occurs. So in general, the acetabular component is either the bearing surfaces. So the acetabular side of it is either polyethylene, metal, or ceramic. The femoral part is either metallic or metal or ceramic. So this is basically a metal on metal because motion occurs between metal on metal. This is a metal on polyethylene. So I'm not talking about any material junction. I'm talking about the motion. In this case, there's no motion between this and this. So the motion is between metal and plastic. And that's why we call it metal on polyethylene. In this case, we have ceramic on ceramic. So you can basically pick any of two permutations. So you can have metal on metal, you can have ceramic on metal, ceramic on ceramic, ceramic on polyethylene. It really depends on the vendor that your surgeon uses. So, but you may hear the terms like hard and soft. So in general, metal and ceramic are hard and polyethylene is soft. So whenever you have metal or ceramic on polyethylene, this is hard and soft. If you have metal or ceramic on metal or ceramic, then this is hard and hard. So why do we care about these bearing surfaces? The significance is because of the wear rate. So you have two surfaces with motion, right? Obviously, over time, there is going to be friction at these surfaces. There is going to be some wear. So the rate of the wear is different depending on the type of the bearing surfaces that you have. And this debris, this wear debris is not good for the body because the body reacts to it. And at the end, you would get a failure of the arthroplasty. So for example, ceramic on ceramic is the best one. And the worst one is probably metal on plastic. So nowadays, the quality of the plastics are much better. So maybe it's not as bad as we see in this picture, but it's nice to know what kind of bearing surfaces we deal with. And in particular, I want to draw your attention to metal on metal because metal on metal is really bad. This metallic debris, body's reaction to metal debris is worse than to plastic particles. So the kind of pathology that you get with this metal debris is different from the pathology that you get with plastic debris. So yes, and we just touched upon this. So with polyethylene on metal, for example, in this case, the green arrow, this motion is between metal and polyethylene. So we get polyethylene wear-induced synovitis. This is known as particle disease. So these plastic particles, they basically, they are in the joint. So you get synovitis because of that. And this synovitis this is so severe that over time it causes erosion of the bone. And that's called particle disease. That's secondary to polyethylene on metal. So, and why do we care about this metal debris? Because these bearing surfaces, because if you know the type of the implant that you're dealing with, then it can tell you what pathology you would expect in that particular setting. On the other side, if you have a metal on metal bearing surfaces, so it can be here between the femoral head and the acetabular cup in a metal on metal arthroplasty, or sometimes we discussed about the taper and the neck, right? So the taper and the neck, obviously we don't have any frank motion, but over time the patients may get really minor micro motions at this level. So this can also be this area is called tronion. So you can also get metal debris from this junction. So as we said, in this case, the pathology, the body reaction is different. So you get two different pathologies. One is metallosis, the other one is adverse local tissue reaction. As a resident level, you don't have to know the difference between metallosis or ALTR. You just mentioned, especially on radiographs, you just mentioned the type of the arthroplasty you're dealing with, and then you can describe your findings. But overall, the body reaction and the MRI appearance is different between the particle disease and reaction to metal debris. Okay, so a brief touch on implant fixation. Sometimes we use cement to fix the implant. So cement is basically a polymer of polymethyl methacrylate, and sometimes they add barium to it to make it radio dense for us to see it better. On radiographs, if there is infection, they add antibiotics. So the way that they do this cementation is that they don't want to fill up the entire medullary canal with this cement, right? So they put a plug over there and they fill the medullary canal with this cement, and then they advance the femoral component into the cement. So if you see something like this, that's a normal bone plug that they put there to prevent cement from filling the entire medullary canal. That's one configuration. The other configuration is cementless. I don't have a case of that, but it's very common. I'm sure you have seen it. So in cementless, they don't use any cement. They just put the implant in the bone. So initially they do press fitting. So, and if you have been to the OR, see the surgeons, but they basically use some hammers and sometimes manual compression to compress the implant on bone. And over time, like starting like 4 to 6 weeks, the bone starts to grow into the surface of the implant. So although we don't have a cement, after 4 to 6 weeks, we have a really good ingrowth into the rough surface of the implant. So that's the logic behind cementless fixation. Then if you have cement on one side, this is called hybrid because you have cemented acetabular component and non-cemented. Cemented femoral component and non-cemented acetabular component. It's the other way. It's the reverse hybrid. Again, many institutions, they don't care if you comment on cementation or hybrid or not. We want to look at the interface that we're going to review in a bit. Another concept that we see in hip is resurfacing. Resurfacing is similar to arthroplasty. The only difference is that it only has this like small peg in the femoral neck. It doesn't have a long stem. So it's better than arthroplasty because we basically save the femoral neck, and obviously all of the complications of the femoral stem are not here. So in most cases, if there is, if for example, there is avascular necrosis of the femoral head, they may start with this thing. Over time, these may, after like a few years, then they may have to switch it to total hip, but at least this is a good bridge to save the bone stop. So resurfacing can be resurfacing hemi. Again, you see the acetabulum, or it can be resurfacing total hip arthroplasty. So you see this outer metallic component and the inner femoral head. Okay. So case 4, left hip pain. So again, we see this fracture, right? So we know why the patient has pain, but what are these rings here? And this patient has it on both sides. So we haven't reviewed them so far. So if we do a CT of the same patient, we see that there is the femoral head, then we have one component here, and then we have the acetabular cuff here. So in this case, there is motion between this component and the acetabular component, and one motion between the femoral head and this component here. But then the ring that we saw on the radiographs corresponds to these metallic densities here. On 3D volume rendering, you see this ring. So this configuration is called a tripolar. So we started with hemi, then conventional arthroplasty, and now this is a tripolar. So this configuration is not really that common, it's rare. In these configurations, you have 2 levels of motion, but you add this locking ring to make sure that the spacer, this spacer that you see here, is not remains in place and it's not dislocated. So they use this configuration in patients who have had prior recurrent dislocation with hip arthroplasty. So after revision, they basically use this tripolar and they put this this interlocking screw. So, and this is how the components. So we have the acetabular cuff, then you have the outer liner, then you have the ring that keeps this liner in place, then you have the bipolar liner, and this is the head. So one level of motion between the head and this liner, one level of motion between this bipolar and this outer line, and this is the lock. So in this case, you can see that the ring on the other side is completely broken. You see that the ring is divided in half. So that's a failed ring. On this side, this one is not like completely parallel to the acetabulum. So there is some degree of motion in the ring. So the ring is loose. And this is after revision surgery. Because of the fracture here, they basically put some cerclage wires and they revise this one. So now in the post-op setting, you can see that this ring is completely parallel to acetabular cuff. Again, this is we have 2 levels of motion. So you can see that the modular component is a little bit rotated, but that's totally fine because we know that there is some motion there. Okay. So case 4, 63-year-old woman with a traumatic hip pain. So I just pause for 10 seconds because we're gonna review this case at the end. So again, total hip arthroplasty, femoral head. This is a standard bearing. So this is metal on polyethylene because it's lucency here. Total hip arthroplasty. So let's move on. Okay. So now let's get familiar with 2 concepts. One concept is loosening, the other one is osteolysis. So loosening in general, it is an intraoperative diagnosis. So I always tell our residents that do not use the term loosening in your reports because loosening, the surgeon has to go inside, they have to play with the implant, pull the implant out, and if the implant is coming out, then that's loose. Otherwise, you cannot make that diagnosis on imaging. However, there are some features on imaging that can suggest loosening or rarely can be definitive of loosening. But in general, try to avoid this terminology, loosening. Osteolysis is a descriptive term, which means basically bone loss at the bone implant interface. So whenever you have focal bone loss around the implant, you can call it osteolysis. It can be caused because of infection. It can be because of metallosis that we discussed. It can be because of the particle disease like reaction to polyethylene. So this is just a descriptive term. And it's technically osteolysis is a form of periprosthetic lucency. So in your radiology report, when you want to just say that there is osteolysis in one particular area, we use this terminology. We have the Charnley zones, which are for the acetabular cup. We have zone 1, 2, and 3. That's it. Superolateral, supermedial, and inferior 1, 2, 3. And we have the Gruen zones. Gruen zones are the femoral stem. Gruen zones, we comment on them on the AP and lateral view, right? So we have 14. So I memorize them really easily. I know that 14 is the number, so I divide it by 2. 7 is for the AP view, 7 is for the lateral. On the AP, I start from the lateral to medial. So 1, 2, 3, 4 is at the tip, 5, 6, 7. On the lateral view, we go from 8 to 14, the same thing. So for example, and this is for hemiarthroplasty, it has its own classification, 1, 2, and 3. We don't see osteolysis surrounding this plate that often, so can let that one go. So for example, I can say there is osteolysis in Gruen zones 1 and 8. This is how you would describe on your report. So what are normal?
Iman, sorry to interrupt. I just want to give us a quick time check. We have about 5 minutes left, so I don't know if you want to get through the final concepts with cases or just to kind of give everyone a heads up on the time.
Okay, so 5 minutes. Okay, I'll try to hurry. So normal periprosthetic lucency, anything that you have that is less than 2 millimeter is normal. So let's see a case here. So what is solid fixation? Anything that is stable over time, it's good. Stability over time is good. Bone ingrowth or spot weld, it's good. This is bone ingrowth going all the way to the surface. So this phenomenon is called spot weld. It's a good thing. It shows that there is bone ingrowth, there is solid osseous fixation. And this is the mag view. Normal or acceptable findings. We said anything that is less than 2 millimeter is normal. Why is that? Because our body can form a fibrous reaction around the implant that is almost always less than 2 millimeters. So 2 millimeter at the cement bone interface or bone implant interface is good. If you have subsidence or inferior migration of the implant, less than 10 millimeter is good. We discussed that we do this on purpose, right? That's good. If you see bubbles in the cement, that's acceptable because it's cement, so sometimes during the surgery, we have air bubbles. If you have a stress shielding, that's also good. So initially, this is 11 years prior, you have normal force distribution here. After this arthroplasty, there is no force on this area, so over time, they get focal demineralization. That's normal. You see on the other side. So findings of possible or probable, any osteolysis, anything that is focal lobulated or more than 2 millimeter in thickness. So 1 year ago, normal interface, this year, there is lucency that is more than 2 millimeters. So that is concerning, right? Pedestal formation, it's area of sclerosis right at the tip of the implant, this thing. This finding can be seen with loosening, right? It's not a spot welding because a spot welding is not at the tip. A spot welding is something here that goes all the way here, but pedestal formation is sclerosis at the tip. So, and in this case, there was bone loss here too. So if you have metallic debris or hardware fracture, obviously these are possible findings for loosening. Same thing with cement. A normal cement should not be discontinuous. Cement fracture is also a finding of possible or probable loosening. Definite loosening is whenever you have frank motion of a component. So this is 6 years ago. Look at the angle of the acetabular cup. Now it's totally vertical. So there is no way for a fixed component to rotate in space, right? So this frank motion is definite finding of loosening. And you can appreciate the osteolysis here, right? So sometimes you see the motion with the femoral stem here, and you see lucency surrounding the femoral stem. That's called windshield wiper effect, and that's also a definite finding of motion. So we said subsidence up to 1 centimeter is okay, but if you have excessive subsidence, more than 1 centimeter, that's concerning for definite loosening. So going back to our case, in this case, I see that the femoral head is not right at the center of the cup. It's eccentrically positioned. So to me, and I know that there is a polyethylene liner here. So to me, it tells me that there is some sort of like liner wear or liner loss over here. So in my mind, I'm thinking I have a liner and there is wear of that liner. So could this be particle disease? Then I look at the bony structures. I see this lobulated area of bone loss here, right? You see this bone loss or so-called osteolysis. So I have osteolysis plus liner wear. That's really good. Putting these together, that's a good finding for particle disease. Again, I look at the middle acetabulum. We see that there is this lucency here. The osteolysis is not just here. It goes all the way medially. And at this point, we have almost disruption or destruction of the cortex. So putting these findings together, this was a case of synovitis secondary to polyethylene debris, also known as particle disease. And with that, I thank you all for listening, and I'm all yours if you have any questions.
Yeah, thank you so much, Iman. That was a really great lecture and great cases to kind of show some of these different things. I think as MSK radiologists, we really love structure function relationships, not just with native anatomy, but with the arthroplasties too. It tells us a lot once we understand those structures, being able then to predict pathology and how they're going to fail and what kind of things we can look for. And I think you did a really great job of going through all those things. And I think, you know, for those of you who are watching, that's a great one to review if you really understand those. So it does look like there's one question here I'd like to direct to you. How do surgeons decide cement versus cementless? If you want to comment on that.
Oh, it's a very personal decision. You have no idea how surgeons, like in one institution, they love cement, they hate the other one. In other institutions, it's the other way around. I can tell you nowadays, at least in my institutions, we see less and less cases of cemented arthroplasties. So most of our total hip arthroplasties are non-cemented. Hemiarthroplasties are mostly cemented. So I don't know, Jennifer, if you have the same trend in your institution.
I would say that we probably do, and I agree. It's a lot of surgeon preference, and I think, you know, like you, I tend to see more of the cemented ones on the hemiarthroplasties, especially in a lot of those older osteoporotic patients who are presenting with the femoral neck fractures. And so I think they probably get early, you know, good fixation early on with the cemented ones in those patients, but there is a lot of surgeon preference there. Any other? I don't see any other questions in the final Q&A. I do want to remind everyone there is going to be a survey link that's going to go into the chat forum here. And I'd appreciate if anyone who watched tonight, you know, can give us some feedback there. We love this series and want to hear from you what are good topics and things that we can do to continue to reach out and provide these educational opportunities. And then I do definitely want to give a lot of thanks, Dr. Khodarahmi, great job. And thank you so much for taking the time and for a great lecture. I want to thank our audience for tuning in. Please be sure to give your feedback, and also to our Veritas staff for helping to run the webinar here. They do a great job. So it does look like the survey link is live now. And I hope that you all enjoyed tonight and that you'll join us for our next one. It's scheduled on April 10th, 2024 at 7 p.m., same time, same station. And it's going to be interesting foot cases presented by Dr. Kara Getke-Udiger. And that will be very interesting and something we see, you know, a lot of. So I hope you all enjoy and can join us again then. Thank you so much.
Thanks, everyone.